Hello, and thank you for joining today's webinar. We'll be starting soon. While you wait, please share where you're joining us from today in the chat.
I can see a lot of people are coming from the US, handful from Canada. I think I saw Malaysia. Hi, hello. Ooh, Saudi Arabia. And of course, New Jersey. I'm a New Jersey person. Oh, Berlin, Germany. Oh, and Dubai. Hmm. Oh my goodness, Alaska. I've yet to visit Alaska. I hear it's beautiful during the summer.
Well, hello everyone, and thank you for joining today's webinar. This webinar is aligned with the type of content you'll find at Sigma's Creating Healthy Work Environments conference that goes from March 20th to the 22nd this year in Washington, D.C. I am currently placing in the chat the link so that if you are curious and registering for this event, you can do it through the link right there. So today's webinar is eligible for one contact hour. Sigma Theta Tau International Honor Society of Nursing is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. No one with the ability to control content has any relevant financial relationships. To receive contact hours for this NCPD session, participants are required to attend the webinar and log into our learning management system to complete an evaluation form. Information on how to access this will be emailed to all attendees 1 week after the webinar. This webinar is being recorded and will be available via the Sigma repository within a few business days of recording. Following the presentation, if we have time, we will have a question and answer session. You'll see on your Zoom webinar control panel that you can send a message through the Q&A feature. This is where you can type in any question you'd like to pose to the presenter. Be sure to hit send so the message makes it to us. Please use the Q&A for questions and the chat feature to interact with other participants. We would like to thank our speaker for sharing their expertise with us today. Of note, thoughts and views expressed are that of the presenter and do not necessarily reflect that of Sigma. Our speaker today is Dr. Al Aguilar. Al Aguilar is a critical care APP at RWJUH, a core team member of New Jersey's first ANCC accredited APP fellowship program, and adjunct faculty at Rutgers School of Nursing, Division of Advanced Nursing Practice. With over 15 years in nursing, with most of it in advanced nursing practice, he cultivates, supports, and guides educational and professional initiatives to strengthen nursing and APP practice. Grounded in collaboration, empowerment, and representation, Al builds pathways that support collective growth, honor those who came before him, and create environments where others can thrive. All right, now Al, tell us what you know.
Thank you. Thanks, Monica, for that introduction. Hi, everybody. Hi from New Jersey. I want to thank everybody for joining me for today's session. This session will focus on an experience that many frontline workers encounter, yet very few of us are ever taught on how to name or let alone process it. It's on the second victim phenomenon, what it is, why it matters, and what evidence suggests could potentially help. Now, some of you out there may connect to this topic personally. The rest of you may be here solely to learn, or perhaps to teach, or Better yet, lead or design safer systems and processes. I'm not asking you to disclose personal experiences, and I'm not asking you to self-identify. The goal of this session is shared understanding. With that said, let's take a look at today's learning outcomes. After this session, you should be able to explain the second victim phenomenon and its impact on frontline workers. So when I'm talking about impact, I'm talking about across specific domains: emotional, psychological, physical, and even professional. The second learning outcome, after this session, you should be able to distinguish between two types of cultures: blame-based and just cultures, and their effects on frontline worker recovery and resilience. The third learning outcome, after this session, you should be able to apply evidence-based strategies to reduce second victim harm. And the last one, after this session, you should be able to integrate second victim awareness and support into clinical practice, into education, and into your organizations. I want to begin with my story. Not really to talk about me, that's not the point in this session at all, but to ground why this topic matters to so many providers and why it matters so much to me. So many years have passed after a difficult case, and I can still remember that day till this day. I remember going home. I was physically exhausted. My body was tired. But even with that, I was wired. I was emotionally wide awake, and my mind wouldn't rest. I can remember replaying the decisions over and over again. What I did, what I didn't do, what I could have done differently, what might have missed. I remember questioning myself a lot. I was questioning my judgment. I wondered whether I'd let my patient down, my colleagues, my teammates down, and whether I let myself down. But what struck me the most wasn't the event itself. It's what happened or didn't happen afterward. I can remember after the event happened, silence. No one said anything. And quite frankly, no one asked how I was doing. And just as importantly, I didn't feel like I was allowed to say anything. I didn't feel like I was allowed to say that I wasn't okay. To this day, I can still remember weeks out, I kept showing up to work. I was functioning. I kept going. It looked like everything was okay. I had a mask on. I was good at that. But on the inside, I was falling apart. And I was carrying the weight of that experience, and I felt alone. Many years have passed, and reflecting on that moment, I realized something important. That wasn't my story. It's a story that many frontline workers live with quietly and sometimes alone. After adverse events, near misses, or outcomes that don't align with our intentions or our values, which I strongly believe are inherently good. And today we're going to talk about that experience. The point in today's session isn't to point fingers or assign blame, and definitely not to relive any trauma, but hopefully to name it, to be able to understand it and process it, and to explore how we can better support not only ourselves, but also each other when these moments inevitably do occur. Now, why does this matter? Adverse events in healthcare affect more than patients and families. If you look in the literature, adverse events actually have three victims. The first victim is the one that we are most familiar with: patients and their loved ones. But there are also two groups of victims: the second and the third victim. The second victim are the clinicians, the providers, the frontline workers who are involved in that adverse event. And the third victim is the organization. I want to reiterate something. Second victim experiences are not merely struggles of the individual. There are repercussions and there are direct implications to patient safety, workforce retention, and even organizational performance. Which then brings us our first poll of the day. I personally love polls because I believe it's an opportunity to get everybody engaged. With this specific poll, I want to get a sense of your baseline familiarity with the second victim phenomenon. I want to reiterate something as well. This isn't about whether you or anyone you know has personally experienced it. So my question for everybody is this. How familiar are you with the second victim phenomenon? Have you never heard of it? Have you heard the term? Are you familiar with the concept, or are you amazing and you're actively teaching and working with it? I'll give you a little bit of time to share your responses in the chat, and please feel free to add any additional details if you're called to do so. So just looking at the chats, I'm seeing a variety of responses. Thank you for staying engaged. We appreciate you. Some have never heard of it, some have heard of it. I'm going to call out some of the individuals out there who are actively teaching. Ms. Abby Partridge, kudos to you. And Ms. Melissa Bush. We need to connect after this. For those of you who never heard of it, I want to thank you for being here and for having a lifelong learner mentality, for willing to learn something new. The fact that you showed up today tells me you care about growth, and I think that matters and that's important. For those of you who heard the term, I think it's a start. Hopefully, we can shift from just recognizing the term of second victim phenomenon to really understanding it. Because we know that organically, once we begin understanding, that it'll shift from awareness to action. And then for those of you who are familiar with the concept, I hope that after this session, it'll fuel your commitment, not to raising awareness alone, but to meaningful action and support. And then for those of you, the ones I've given shout outs to, for those of you actively teaching or working with it, I want to thank you for doing the work that you're doing. You're contributing to a more supportive culture, and that culture that you are cultivating is allowing our colleagues, our frontline workers, the opportunity to process and recover and continue providing safe patient care. So, what exactly is a second victim phenomenon? Whether I'm coming from a place of either learning or teaching about a specific topic or concept, I find that using mnemonics tend to mitigate the cognitive overload. So for second victim phenomenon, I think of it in that way as well. I use mnemonics. In this case, I use the five W's. What, when, who, where, and arguably the most important, why not blame? So, what is it and when does it occur? Well, the second victim phenomenon describes the impact that frontline workers may experience following an adverse event. Now, when I'm talking about impact, I'm talking about impact across specific domains: emotional, psychological, physical, and professional. When I'm referring to an adverse event, it could be medical errors, unexpected patient deterioration, patient injury, death, or simply even a near miss. Who does it affect? Let me tell you something. It does not discriminate. Nurses, advanced practice providers, physicians, trainees, any interprofessional team member who is patient facing, who's involved in direct patient care, may all experience distress following unanticipated clinical outcomes. And it's especially prevalent in high acuity, high risk clinical settings. So if you work in the emergency department, anesthesia, surgery, or if you're like me and you've been in critical care for over a decade, you are at high risk for experiencing second victim phenomenon. And the last W, why not blame? I would say this is the most important. This is not and should not be about blame. It's about recognizing that clinicians, that providers, that frontline workers, that we are humans. We are not infallible, and we are practicing inside complex, high-risk systems. Naming the experience matters. Many clinicians describe a sense of relief when they finally have language for this experience. Giving it a name doesn't make us more flawed or make us less than or not enough. It doesn't pathologize us. Instead, it normalizes outcomes when people like us, people who are passionate and who care deeply about what we do and about caring for others, are exposed to harm. Giving this experience a name, such as second victim, is important because it legitimizes our experiences and creates a shared language, not only for understanding, but above all else for support. If you're looking at the literature, a lot of the content experts and a lot of the authors are even shifting from the term of second victim to identified individual. And this is particularly prevalent in specific support program contexts, where the intention is to reduce stigma associated with a label. And so avoiding labels is emphasized. And part of the reason they want to do that is because they want to make sure that support is available, irrespective of whether or not someone identifies as a victim. Some take it up another notch, where the emphasis is on access over labels, where they feel and believe that clinicians, that providers should receive support without having to name or define their experience. Proponents of this approach believe that this will lower barriers to care, promote psychological safety within that workplace, and make sure that support is based on need rather than identity. By having this perspective, there's a shift that's intentional, that focuses this shift from who qualifies to making support available, period. Ultimately, naming the experience matters because it facilitates access to support. Now, how common is this? What often surprises a lot of people is just how common it is. Regardless of what discipline you're in, what subspecialty you are, regardless of the years of experience you may have, most clinicians will experience a second victim response at least once during their careers, and many will experience it more than once, particularly if you're in that high risk, high acuity environment, emergency departments, anesthesia, surgery, and critical care. When you look in the literature, some of the studies suggest that up to 40% of healthcare professionals report a second victim experience. Now, I can tell you confidently that regardless of what the literature is saying right now, as of this moment, it is still under-recognized and underreported. So these estimates are underestimated. So why does this matter professionally? Well, when these experiences go unrecognized or the second victim feels not acknowledged or unsupported, it doesn't simply go away. What ends up happening is that their confidence is eroding. They're less passionate or less engaged. And in certain cases, some second victims end up leaving the profession altogether. As you can see here, it doesn't only affect the individual, but it creates a ripple effect where it affects the organization itself. So, on an individual level, it leads to burnout, absenteeism, increase in attrition rates. And for those providers who have prescriptive privileges, they may end up ordering unnecessary tests because they're going to practice defensively, which translates into increased cost. And there's an overall increased risk of future errors, which we know there are repercussions to the organizations, adversely affecting staffing and workforce stability. There's a decrease in team morale and psychological safety. And we all know that that translates into less safety for our patients and worse quality outcomes. And for this reason, supporting our second victims is not merely a checkbox. It's not merely a wellness initiative. It's a quality and safety imperative. Which brings us to our next poll. It's about organizational awareness. And the question is simple. Does your organization have a formal second victim support structure? Your options are yes, it's clearly defined. Yes, but it's informal. We're all a work in progress. You're not sure, or the answer is a no. I'll give you time to add your responses in the chat. And again, I'm totally open for any insight. We're all a work in progress. I strongly believe in that. But if you have any formal structures in place, please share. I'm looking through the responses. I'm seeing a lot of people very forthcoming and transparent. I love it. Thank you for your transparency. Oh, I see a yes from Ms. Beeson. And I see a yes that's informal from Ms. Nancy. I'm sorry, Nancy. I don't want to butcher your last name, so I'm not going to say it. Some informal from Miss Tamara. Ooh, and Miss Joanne, a restorative clinical supervision. Oh, we have to connect afterwards. Please find me. I'm on LinkedIn. Oh, and Kathleen, thank you for pointing out a great resource, AHRQ. So for those of you who did respond no, I want to say shout out to you. I appreciate your honesty. Just because there's no structure in place, it doesn't mean that there's no need for this. I see that as an opportunity. The obstacle is the way. For those of you who responded, you're not sure. It likely means it's been talked about, but it has yet to be embedded into your organization's culture. And then for those of you who responded with yes, but it's informal, I still think that's a start. Although, if you look in the literature, formal pathways are what are recommended so that access is consistent. And for those of you who say that you have formal structures, oh my goodness, oof, kudos to you. You have a strong foundation. Please share. After all, psychological safety determines whether it can truly work and whether it will be sustainable or not. So, what does a second victim experience look like? As I mentioned before, it shows up across three overlapping domains: psychological, physical, and professional. Now, not every clinician is going to experience all of these, and not everyone experiences them in the same way. After all, we're all different. We all have different lived experiences. But these are patterns that are consistent, are recurrent across the literature. Now, many of these responses are initially protective because the mind and body are interconnected. They are a reflection of the mind and body trying to understand and process what transpired in an effort to get a better sense of it and in an effort to gain control and hopefully prevent future harm. Unfortunately, it does become challenging when second victims feel like they're alone and they have to deal with it in isolation, often without acknowledgement or support. So, what ends up happening when a second victim has no acknowledgments or supports? This leads to the psychological, physical, and even professional impact typically associated with the second victim phenomenon. In the immediate phase, psychologically, second victims may end up experiencing guilt and shame, or may have intrusive thoughts, paralyzing anxiety, and a loss of confidence. If this is not addressed, and if it's severe or prolonged, it can lead to depression. It can even mimic PTSD. Worst case scenario, some second victims have thought about hurting or killing themselves, and some unfortunately have. Because we know that the mind and body are interconnected, psychological sequelae also manifest physically: insomnia, fatigue, GI symptoms like acid reflux or GERD, and difficulty concentrating. And what I want to reiterate here is that these can happen not necessarily after just adverse outcomes. It may even occur after near misses. And so this leads to professional sequelae. Now, looking at this, some of you are probably thinking, oh, short-term response. So the second victim is going to be a little self-critical, but that individual will be a little bit more cautious and hypervigilant. So that would likely be beneficial to the patient, right? So that might be an immediate adaptive response. But over time, that is not sustainable. It's going to erode that individual's confidence. They'll feel less passionate. They'll feel less joy and less engagement. It's exhausting staying in that state of mind. And that leads to your long-term sequelae, less job satisfaction. It can even adversely affect relationships, not only professionally, but even personal relationship. It can affect the home life. And that leads to not wanting to show up to work, or in certain cases, thinking about leaving the profession. So as you can see, these outcomes don't only affect the individual, the second victim, but because we are all connected, it can cause a ripple effect for our patients in the future, for our teams and our healthcare systems. If you haven't gotten the sense of this, I'm very into reflecting, taking a step back and pausing. So I think it's worthwhile doing that right now. I don't expect you to necessarily share if you don't like to or you prefer not to, but I want you to just think about this, particularly after these questions. If a colleague, a learner, or team member were experiencing the second victim phenomenon, would you recognize it? Would you feel confident identifying the signs? And then the next question, would you know what to do next or where to guide them for support? If you'd like to, please drop a brief thought in the chat. Ooh, Ms. May, she's talking about intuition. As healthcare providers, as nurses, we are intuitive and we're generally empathic. Ozelina's saying yes, but I will not know what to do. Ooh, yes, available to be a sounding board. Thank you. Oh, Ms. May, yes. Some have a fear of litigation. Ooh, I'm seeing some terms like debriefing. Oh, Meredith, yes. Signs vary from person to person, and even the same person from episode to episode. You are absolutely correct in saying that. Well said. So, for those of you who are confident in recognizing or identifying the signs of the second victim phenomenon, I think that's great because having the confidence to be able to recognize this are very important first steps. I encourage you, though, to take the next step and make sure that when we approach the second victim, that individual feels supported. For those who aren't sure, again, I appreciate transparency and honesty. I think we need a little bit more of that in this world. Just because you're not sure, it doesn't mean you're less than or you're not enough. And as some of you have mentioned, because we are nurses, we have a sense about things and we are empathic. So we know if something is off, but sometimes we may not be able to name it. I think part of the reason we haven't been able to do that is because we haven't really talked about it. We didn't have a language for it, and we weren't equipped with tools to be able to navigate through it. Or perhaps there's just gaps within the organization. And that's why sessions like these, conversations like these matter. So no one would have to feel like they're navigating this alone. And for those of you who wouldn't recognize it, thank you again for being forthcoming. Many signs of second victim phenomenon are subtle, and some second victims are good at holding up a mask. And I can tell you because I was definitely one of them. I'm very good at making it seem like I'm okay when I'm not. So again, to reiterate, sometimes it's a lack of exposure or training rather than the absence of a need. I do appreciate all of you also contributing that you know what to do next. I think that with the knowledge and the experience and expertise that you have, I think it's worthwhile sharing it with your other colleagues. For those of you who wouldn't know what to do next, whether you believe it or not, that's more common than we'd like to think. Sometimes without clear pathways or systems or structures in place, even those of us, many of us who are well-intentioned, can feel stuck. So I see that as an opportunity where we can build processes and systems that are visible and reliable. And I want to reiterate something. The goal of this session isn't perfection, but progress. Again, we're all a work in progress. And I also want to assert and reiterate that support doesn't and shouldn't depend on one person. That is not realistic and that is not feasible. It should be contingent on systems and it should be based on the organization's culture. Which brings us to this point. What shapes the recovery of second victims, above all else, is the culture of the organization. The trajectory following an adverse event is shaped less by the event itself and more by how the individuals within that organization respond to that event. In fact, the culture of the organization plays a significant role in whether the second victim feels psychologically safe enough to ask for help or support after an adverse event. After all, if someone feels safe in an environment, he is more likely to speak up, is more likely to want to connect with other people, and that will subsequently foster healing. And a big part of shaping that organization's culture comes down to leadership, to all the leaders out there. Although honestly, I feel that all of us are leaders in our own way. When I'm referring to leaders, I'm talking about those of you who have a formal title or role or currency within your institution or organization. You are the role models. You dictate what is permissible. You dictate how others are going to respond or react to certain events. And you are the one responsible for setting the tone. So, to all my leaders out there, it's up to you to establish or cultivate a certain culture within your organization, particularly after an adverse event. And we know, looking at the literature, there are two types of culture that permeate after an adverse event. There's a blame culture and a just culture. In blame cultures, second victims are fearful of reporting errors because it's typically associated with shame. There's a worry about being punished, or there's a worry about reputational harm. In a blame culture, the individual is to blame. Mistakes are individualized. There are finger pointing. That individual is at fault. There's no consideration for any other confounding variables like process or system inefficiencies or deficiencies. That person is to blame. So what would you expect? Of course, that person's not going to say anything. In a blame culture, perfectionism is expected. If you are not infallible as a healthcare provider, then perhaps you have to reconsider being in the profession because you're not worthy to be in this profession. That's the blame culture. So what ends up happening? No one talks about it. It's underreported. And ultimately, if the individual caring for our patients doesn't feel safe, it ends up undermining patient safety and allows harm to persist. On the other hand, you have a just culture. When adverse events happen, just cultures examine errors through a systems lens. Now, please don't make the false assumption that I'm saying that that eliminates accountability. That is not the case at all. Rather, in just cultures, there's a balance between accountability of the second victim along with an opportunity for improvement or learning, as well as fairness, respect, and support. Lastly, a culture of patient safety cannot exist without psychological safety. And just cultures allow for psychological safety. After all, if frontline workers feel that they are in a space where they are safe and they're taken care of, guess what? That's a ripple effect. They're more likely to take better care of our patients, which then brings us to the next poll, cultural climates. Now, I want to say this. This isn't about judging or naming or calling out any organization. That is not the intention of this poll. It's emphasizing the importance of culture and how culture shapes experience, especially after an adverse event. I also want to say something that culture isn't always uniform. In fact, even within the same organization, responses can vary a lot depending on multiple factors: the context, the actual event itself, leadership, the team dynamics, and psychological safety. As you're thinking about responding to this, what I want you to think about is how your work environment typically feels. So I want you to take a step back and see how your work environment felt to you after an adverse event. Does it feel more like a blame culture where it's punitive? Or is it more of a just culture where there's an emphasis on opportunities for improvement and learning and growth and support? Is it mixed? Or you're not sure? I'm seeing a lot of mixed, a handful of supportive, but mostly mixed. Ooh, I saw Miss Joanne has very supportive. Oh, Miss Joanne, we have to connect. Ooh, punitive. Ooh, that is not ideal. We're all a work in progress. I just want to reiterate that. Thank you, everybody, for responding honestly. For those of you who selected supportive, oh, brings me joy. Yes. Woo. I want to reiterate something about a supportive organization or an organization that fosters or cultivates a just culture. Just culture doesn't mean you're turning the other cheek or you're giving somebody a free pass. It doesn't eliminate accountability. What just cultures do is that they balance learning and system awareness. For those of you who are forthcoming in saying that your environment feels punitive, I want to say thank you for your transparency and for being honest. As I mentioned prior, a blame culture is less than ideal. It leads to silence and fear. And for me, I see a lot of these things as opportunities to grow and to improve. After all, when people feel scrutinized rather than supported, they're not likely to say anything about it. And there's your opportunity to change and to improve or learn for the better. So it doesn't only adversely affect morale, but also patient safety. And then for those of you, for many of you who said mixed, a mixed response tells us that culture, even in one organization, isn't static, it's dynamic. So I think one of you even mentioned that it's contingent on leadership, and you are absolutely right. And on top of that, it's also contingent on how severe the event was and who was involved in that specific event. Now that we've talked about what second victim phenomenon is, who it affects, the impact it has, and the importance of organizational culture, many of you are probably wondering, what can I do to help? Well, what actually helps? If you look in the literature, specifically the qualitative studies that ask second victim themselves, what actually helps? What helps the most and helps first is peer support. And not just any support, but timely, non-judgmental responses, particularly from somebody who, quote unquote, gets it. So it's a trusted colleague or peer who may have experienced that or have or has known somebody who's experienced that. Peer validation matters early. It can reduce isolation and distress before it escalates. Now, as you can see, there are other methods that could also help supporting layers. such as formalized debriefing processes and even leadership check-ins. But they work best as a multi-pronged or multifaceted approach. And finally, I can't emphasize the importance of structured programs. After all, when support depends solely on something that's informal or perhaps ad hoc, unfortunately, people end up falling through the cracks. So, what does a structured support look like? Well, first things first, it should not be a one size fits all. After all, because we are all different and we have different lived experiences, we should have access to the right level of support at the right time. That's why the most effective programs out there use tiered support models. These models allow second victims to step in at the level that matches their needs and move to a specific segment or tier if necessary. So as you can see, there are three tiers here. You have tier one, which is your local support. So these are your trusted colleagues, peers, your immediate supervisors who can offer immediate peer-based validation. Then you have tier two. Tier two is a little bit more structured and formal. It includes peer supporters who are trained in facilitated debriefings, for instance. So there's structured guidance. And then tier three involves professional support. So you're going to think about employee assistance programs or professional therapy. These are for second victims who have higher acuity needs. Now, if you look in the literature, only a minority of second victims actually require tier three. And part of the reason is because many of them benefit from tier one and tier two, which prevents escalation in the first place. So when I look back on my experience many years ago, I realized something. What I needed the most wasn't answers. It was acknowledgement. What I needed was a language to name it, to figure out what it was and what was happening. And above all else, what I needed was support to help keep me going. I want to say this. Supporting second victims after harm isn't about turning the other cheek or being lenient or being soft or not holding anybody accountable. It's not to erase what happened. It's about protecting our patients, strengthening our teams, and sustaining our workforce. So, what does this recovery process look like for the second victim? In the literature, there is an established recovery model that's highlighted in 6 stages to give an overview of what a second victim typically goes through. Starts off with stage one. It begins with chaos. Here, the event is identified, and the second victim experiences an acute stress response. It's in the form of shock, fear, and a sense of things spiraling or moving really fast. Then you proceed with stage two, rumination, intrusive reflections. Here, the second victim replays the event over and over again. There's a lot of self-doubt. And the second victim tends to withdraw or isolate as he tries to make sense of what happens. Then you have stage three. There's a struggle in trying to restore personal integrity. Here, you still have rumination, intrusive reflections, but now the focus shifts to identity. He may end up questioning himself. Is he cut out for this? Is he really aligning with his values as he say he is? And is he supposed to really still continue caring for patients even after this event? Is he still worthy? Then comes stage four, which many describe as the Inquisition. Now, I believe some of you already mentioned in the chat as well that some of Your colleagues at work have experienced this and during the Inquisition, where second victims worry about consequences, legal, such as lawsuits, organizational consequences, lack of job security, they could get fired, or professional consequences, reputational harm. In this stage, fear of judgment often overshadows healing, which then brings us to stage five. Stage five is referred to as emotional first aid. Here, support is very critical. At this stage, the second victim may reach out to individuals they care for and who in return care for them as well to get a sense of understanding, acknowledgement, validation, and support. I would say stage five is probably the most important out of the recovery model because the level of support or lack thereof that the second victim receives will dictate what happens in stage six, which is referred to as moving on. For stage six, outcomes vary. Some second victims end up leaving altogether. They're no longer in healthcare. Others survive and are practicing, and others ultimately grow. Some end up reconciling the experience, transmuting the experience in a way that reshapes not only their practice, but their identity. I want to reiterate something also. Although it looks like it's linear, stage one to six, this recovery process is not linear at all. In fact, many second victims may actually move back and forth between stages. Some may end up skipping a stage. Some may end up sitting in a stage longer than other stages. It's really dependent on the support or lack thereof it that can influence where they end up landing. So, looking at where a second victim may end up landing, we'll look at stage six, referred to as moving on. The moving on stage exists on a continuum, dropping out, surviving, and thriving. This stage isn't about judging whether or not somebody was competent to begin with, or it's not a predictor of whether or not that individual is going to be successful in their career moving forward. What this stage tells us is whether or not the second victim was able to heal after the events. And again, whether or not adequate support was available. All the way to the left, some second victims end up dropping out. In other words, the second victim leaves that single challenging event, likely because there was inadequate support. Now, some of you are probably saying or thinking, well, maybe that person wasn't really cut out for this role. Maybe they weren't meant to do this. Okay, that may seem like a resolution. Even so, that individual is going to carry that inside. And we know that we're all interconnected, so that can cause a ripple effect. Even if that individual doesn't work in healthcare, that's a burden to carry, and that can cause a ripple effect into their personal lives. Some others end up surviving. Content experts refer to this as presenteeism. So that means that the second victim may end up staying in practice, but he is functioning below his pre-event baseline. So he's showing up, but he's still carrying the weight of experience, and he may not be as passionate or as engaged as he used to be. Then at the end of this continuum is thriving. Many refer to this as post-traumatic growth. Essentially, this means that the second victim doesn't become hardened by the experience. It means that the second victim is able to learn from the event, is trying to reconcile the events and take the lessons learned, transmute that experience into trying to make it better for others so others will not have to experience the same thing. And this is where resilience comes in. Now I'm going to talk about call to actions. To all my fellow clinicians out there, to my fellow educators, And to all the leaders out there, I have calls to action for each of you. To my fellow clinicians, to the frontline workers out there, ooh, you are the first line of support. Second victim experiences are common. Now, although formal programs are nice and they're ideal, I want to say that it doesn't begin with formal programs. It begins with you. So, what can you do? First, know your support resources before you or somebody else needs them. Just thinking out loud, peer support, employee assistance programs, or maybe start a structured or formalized debriefing process, which I think some of you already have in place. Another thing you can do is normalize check-ins, particularly after adverse events or difficult cases. The intent is not to try to fix anything. Don't try to analyze. We tend to do that. Just ask the other person, how are you doing? Listen without judgment. Don't try to minimize it. Don't try to solve anything. I can tell you confidently that just being present for that person speaks volumes more than trying to say scripted perfect words. And then the last part, model psychological safety. When you talk about difficult cases honestly, you give space for the other person to feel safe to do the same. And I can tell you that anecdotally and confidently, being in both ends, being a second victim and being a support of a second victim. At my place of work, I can tell you many of my colleagues across disciplines, nurses, APPs, physicians, they've come to me because they know that they can trust me and they can lean on me. Because sometimes the difference between surviving and thriving is that one person who noticed and who cared. To all my fellow educators out there, you shape the culture before they enter practice. Now, I can say confidently that many institutions and organizations, universities, hospitals, do not formally prepare providers to cope with adverse events. It's not in the educational curricula at universities. It is not in orientation programs for new hires. And we can change that. Second victim phenomenon, I think, should be mandated in all curricula. So, what can you do to all my educators out there, whether you're an educator in academia or you're in professional development in a hospital? Teach it explicitly, put it in that curriculum. Ideally, integrate structured debriefing into training and then frame debriefing as an expectation, not an exception. Make it a part of professional practice. Normalize it. When you normalize it, it signals that you're in a psychological safe space and that you value opportunities for learning and growth and that it's not associated with incompetence or failure or not enoughness. For any of you who are in simulation, I love simulation. I think it's the wave of the future. This is a great opportunity to integrate that. I can tell you we do this a lot for our APP fellows. And then lastly, teach recovery stages. When learners understand that the second victim experience exists and they know what it looks like and what to look out for, they're less likely to interpret it as incompetence or not enoughness or failure. To all my educators out there, you're not just teaching clinical skills. You have a lot of influence and impact. You have the ability to shape the culture and resilience in the future of our profession. So be proud of what you do. And to all my leaders, again, like I said earlier on, I think we're all leaders in our own way. But I'm talking about the leaders out there with formal titles or roles or currency in your institution or organization. I want to say something. I'm going to be real with you. Intention isn't enough. Only about half of hospitals even have second victim protocols. And on top of that, many providers aren't even aware of resources available to them. So, what can you do? If possible, invest in tiered support structures. Now, if tier two and tier three aren't feasible, what I highly recommend is to integrate an educational curricula and let's say your orientation programs. So then you're going to give an opportunity for fostering or cultivating an environment that allows peer check-ins. Regardless, support should be visible, accessible, and confidential. Second thing, adopt and reinforce a just culture. Again, it's your responsibility to set the tone and set the environment for what transpires after an adverse event. Investigate the intention because we know that there's a difference in a second victim who may have contributed to the adverse event due to reckless behavior versus there being system and or process inefficiencies or deficiencies. Additionally, please replace blame with opportunities for growth and learning. Third, I'm biased. I like implementation science and research. Track outcomes. Get the data. If we don't measure that, we're intentionally signaling that it doesn't matter. And then lastly, protect psychological safety of your employees, of the frontline workers. After all, if your patient-facing colleagues feel safe within that environment, they're going to feel more empowered to want to do better and take better care of their patients, which is a win-win for everybody. I'm about to wrap it up now. I want to say many things. So it's a recap. Supporting second victims is not about being soft. It's not about turning the other cheek or being weak. It's a safety issue. As I mentioned earlier on, I'm going to say this again. I am a broken record right now. Making sure that frontline workers, patient-facing colleagues are feeling psychologically safe within their work environment is only going to enable patient safety. So when we care for clinicians, it ultimately benefits the patients that we care for. And when we do this well, the culture begins to shift into one that allows second victims to feel like they're cared for and for providers to feel like they can check in on one another. And difficult cases won't have to be carried alone or in isolation. And there's going to be support. Structured debriefing is an expectation, it's a norm, it's not an exception. And just culture replaces blame culture. And ultimately, this is my vision. Second, victim awareness becomes embedded in clinical practice, in educational curricula, in organizations globally. I'd like to close with a few words. For any of you in this space who's been affected, or for any of you who know someone who's affected, please know that you are human. You are not alone. I'm also a quote person. I love quotes. So I'm going to end with a quote by former US Surgeon General Dr. Vivek Murthy. And I love this quote because it highlights the importance of self-care. Because admittedly, I think we're all guilty of not doing that for ourselves. We're great at caring for other people, but not so much for ourselves. Those who have the privilege to care for others must also have the permission to care for themselves. I want to thank everybody for being here, for continuing to show up, and for doing the work that you do. Thank you. Thank you, everybody. Oh, you're all so kind.
Hi. Okay. Sorry, I was clicking around, having some issues.
Oh, no, it's okay,
Um,
Monica.
Okay, so thank you so much to our presenter today for sharing their story. Sigma's grateful that you took the time to share with this audience and look forward to hearing more from you in the future. If you guys have any questions, feel free to email us at education@sigmanursing.org. We can pass those questions on to our presenter here. Okay, so I will put the link in the chat um, to receive your contact hours. You could click that link and it will take you to our learning management platform. Um, it is technically a course. It is not just the survey, but you do not need to watch anything. You do not need to do anything other than say that yes, you watched the webinar and then take the survey. So it should take you just a couple of minutes to do. And again, if any of you guys have any questions, any problems with getting your contact hours, please email us at education@sigmanursing.org. Um, I'll put that in the chat as well. And we will be more than happy to help you with anything that you need. All right, I hope you guys have a great day and thank you so much for being here for this webinar.
Thank you, everybody. Have a good one.